So we'll just start with a question. What is the typical stenosis of this type of access? And the way that my questions are structured is really, it's not an online question, it's just I want you to think about it, form an opinion, and then we'll discuss it. And so the typical location for this type of access, juxtaanastomotic valve-associated stenosis in the body of the access, cephalic arch, arterial anastomosis. Just go back, show you the photo again. It's an upper arm access. All right. In this case, it's the cephalic arch, and we'll go a little bit about the stenosis that you typically find. Here's the angiogram of an upper arm brachiocephalic vein fistula, and you can see here there's some inflow narrowing, which is very typical for this type of stenosis in the presence of surgery, moving the vessel around. There's often a little squishiness. In addition, you have these valves, and then towards the shoulder, you often have a cephalic arch stenosis, which is a preformed site of stenosis in an upper arm brachiocephalic vein because you get turbulent flow along the cephalic arch, and that leads to vein injury and endothelial proliferation. And so you can see this access now, several years down the road, has seen some injury where you basically still have kind of the narrowings in the inflow, and we never touched those, but you can see that this patient has acquired a cephalic arch stent graft, and then the vein in between the stent graft and the normal cannulation segment that's appropriately dilated is also narrowed and has these recurrent stenosis, so that this patient really has several procedures each year, maintenance that you're probably familiar with if you follow dialysis patients in the unit. And that's not uncommon. And with the use of stent grafts, you can often get a stable outflow there, and once the outflow is long-term patent, you often have kind of fewer interventions that are needed to kind of keep the access going. But interesting to see the inflow stenosis we often keep, because even a small narrow stenosis like this will have flow volumes in the 1,000 liter range, which is plenty for dialysis. So cephalic arch stenosis is really kind of the associated stenosis with an upper arm brachiocephalic vein fistula. There are other typical stenoses that go with different types of accesses. So here you have several options on the left of accesses, and then you have types of stenoses, and then you have the different combinations, right? If you just think in your head, radiocephalic, what kind of stenosis is that? And the right combinations here are radiocephalic has a juxtaanastomotic stenosis, often at the inflow, because the flow is relatively low. Brachiocephalic, we talked about the cephalic arch. If you transpose the basilic vein, then you get a swing point stenosis, and that's kind of the typical point there. And in a graft, you go from zero flow to often 1,200 to 1,500 flow, from 0 to 1,500, and that typically causes an injury of the endothelium of the vein that it's connected to, so venous anastomotic stenosis. And these are the locations of typical stenosis. So if you look at forearm fistulas on the left, about 50% of the stenoses that are found in a forearm fistula are in that juxtaanastomotic site. It's in part driven by the culture of using flows in the 400 to 500 range in the United States. In other countries, often dialysis is performed only with 250 flow per minute. Can be done because maybe people are smaller there or they do longer hours. But if you allow flows of down to 250 per minute, then you often don't have to treat an inflow stenosis for a much longer period of time, because lower flow is permissive and you just leave that stenosis. But we often have to treat them. So this is data from America. On the right, you see that in an upper arm brachiocephalic vein fistula, slightly over 50% of the stenosis that are found and relevant are in the cephalic arch. For grafts, it's even more. Venous anastomotic stenosis, about 75%, or the combination of venous anastomotic and immediate outflow stenosis are about 65% of all stenosis in grafts are right there. And they're very effectively treated now with stent grafts. So that's a standard procedure that you've probably seen in many patients used. So overall, the term that I want you to kind of introduce in your thinking is that in addition to chronic kidney disease, somebody who's on dialysis acquires chronic access disease. These stenoses are always recurrent. You may put a stent in there, but the stent itself will accumulate material on the inside wall and cause another stenosis. So we talked about the venous anastomosis, the cephalic arch, the swing point. Sometimes you have to ligate or modify a vessel. Those sites of surgical injury, again, can develop a stenosis. And then placing, then the biology of increased flow through the vessel can induce venous injury if the flow is very high. Additionally, once you have thrombus in there, thrombus can initiate a biological program inside a vein that leads to progressive scarring. So sometimes we do thrombectomies after, not maybe one day, but after several days. That vein injury, as you saw in that first slide, where the vein kind of narrowed down in the cephalic vein, that patient, once there's thrombus exposure, some veins segments will just continue to sclerose down, and you either have to surgically replace them or you have to place a stent graft to take that segment out of kind of a responsive circuit. In addition, angioplasty itself in models of experimental models is actually a stimulus for injury. So sometimes when you have a vessel that has a mild narrowing and somebody puts a balloon there, that narrowing may come back more severely. So we should only treat narrowings that are hemodynamically or clinically relevant. So they cause bleeding after needle removal, they cause poor clearance, etc. If you just angiographically see a narrowing, those are not the ones that practitioners should actually address. Stent grafts are foreign material, I mentioned that. They can have narrowing on the inside just by deposition of biological material. And then if you have needle insertions by itself, they can carry fibrocytes into grafts and then cause stenosis on grafts inside. They can also, if they're placed in the same area all the time, in a fistula cause kind of a narrowing at the side where the needle frequently ends, similar to a bunion on a foot. So you can angiographically see that the site of stenosis correlates with frequent use patterns of needle insertion. Let's move to the next observation here. So this is the photo that we saw in the initial picture, brachiocephalic vein fistula. And then you see over time, within 1 year, a slight increase in the size of the needle insertion sites. A few years later, the needle insertion sites are even bigger, and then yet another year later, they look like they're going to pop at some point. So the question is, why does this happen? Right? And, you know, I'll put some things out there. You have a recurrent outflow stenosis. Needles always go in the same spot. There's too much flow coming in. This only happens in elderly men that drink a lot of wine. Or it is a race and age related thing. So I put some options there. The ones that I'm kind of looking for, because this is a didactic talk, is the ones where you have a stenosis in the outflow, where you think about how much blood is coming in and how well do you rotate your needles, because healing of needle insertion sites is a process that's affected by how much tension is in the access. So you have to think of it as healing under pressure, and if you have healing under pressure, then the cells will just add on and add on to the layer, as if, you know, people who gain weight, they get bigger and bigger bellies and the skin stretches. Here, if the needle is put in and pulled out, it heals under tension and you get increasing aneurysms with intact, relatively intact appearing skin.